We will speak about EUS and gallstone disease. And just to tell something to go into the problem, we can say that in the last 40 years, there have been major developments in management of this disease that represent a major health problem. And for sure, we have 4 points in the last 30 years that have changed our management and our options. The first was ERCP, that became a widely available and routine procedure. And the second is laparoscopic cholecystectomy, largely replaced the open one, and also with the laparoscopic common bile duct exploration in some cases. There are new imaging modalities, not so new, to tell you the truth, that are MRCP and EUS. And you know that stones are not the same. There are pigment stones, cholesterol stones, and both are different, and also they have different risk factors. Most of the patients with this disease are asymptomatic in 60–80% of cases, and independent risk factors for symptoms are the female gender, the advanced age, and large and multiple stones. Just to go directly in medias res, we will use some guidelines to speak about this problem. The old UK guidelines of 2008 has been recently revised in 2017 by Williams and co-workers, and in these guidelines we find again the recommendation that the discussion, the management must be multidisciplinary. It is recommended that patients with common bile duct stone are offered stone extraction if possible, even if the evidence of benefit is greatest only for symptomatic patient and not for asymptomatic patient. In effect, there are no controlled studies on the natural history of incidentally discovered gallstones in asymptomatic patients, and so in this patient we should tell them that the advice to undergo stone therapy is based from evidence from symptomatic patients and expert opinion, if you want. Another statement, transabdominal ultrasound and blood tests are recommended, but you must pay attention that normal results do not preclude further investigation if the suspicion remains high. MRCP and EUS are both recommended as highly accurate tests for common bile duct stones in patients with an intermediate risk of probability or risk of a disease. What is this?
Press OK. Press OK. It's stupid message.
Okay. But MRCP predominate on EUS in clinical practice. The choice between the two tests should be based on the individual suitability, availability, local expertise, and patient acceptability. Let's take a few steps backwards and speak a little about which was the standard, the gold standard test for the diagnosis of biliary stones. In the past, it was ERCP, but you know that ERCP has a technical failure in 3–10% of cases. There can be underdiagnosed stone up to 10% of cases, and ERCP plus sphincterotomy has morbidity and mortality, of course. ERCP should be only today a therapeutic modality and only in patients with high probability of bile duct stone. So we are looking for a near-perfect, non-invasive method for the diagnosis of extrahepatic cholestasis, and this test should be non-invasive, have low cost, have a very high negative predicted value, and an acceptable positive predicted value. So EUS seems, from literature data, to be a good candidate. This is an old meta-analysis about the performances of EUS in suspected choledocholithiasis. EUS for sure is a non-invasive test or little invasive test with excellent overall sensitivity and specificity for diagnosis common bile duct stones. And if we look at the limits of the abdominal ultrasound at the complication of diagnostic ERCP, we must say that in the setting of biliary stones, EUS has a very high sensitivity for gallbladder stones, so a very high sensitivity above 93% for common bile duct stones, with a very little morbidity and mortality. And these are all studies in the 90s, 11 studies or prospective studies, demonstrating that the sensitivity, the specificity, and the accuracy of EUS are very high. But then we have some very important US competitors, and the most important has been in pancreatic biliary imaging, as you already heard by the previous speaker, the magnetic resonance cholangiopancreatography, and these are the results about sensitivity and specificity of MRCP in common bile duct stone. The problem is when we have a small stone, less than 6 or 5 millimeters, in which the sensitivity of MRCP is much lower. This is an old systematic review. We have much more modern systematic review, but also in this case, in 2006, they are assuming that EUS and MRCP have both high diagnostic performance overall, and there are no statistically significant difference between the two tests. But there is a difference in sensitivity if you look at the graphic, and this is because the EUS resolution is tenfold less than, better than the resolution of MRI. Again, this is another study demonstrated that for a small stone, EUS is better. And this is, in my mind, a very old study, but very important. And if you want to establish a normal biliary tree, you must use EUS because the specificity is significantly better than the specificity of MRCP. And the overall accuracy of MRCP for any abnormalities was 61% versus 89% of EUS. So when compared with initial ERCP or initial MRCP, EUS was the most cost-effective initial imaging modality for patients with the stones or extrahepatic biliary disease. So we can say that the EUS and MRCP have comparable accuracy, but the EUS has better sensitivity in the diagnosis of extrahepatic cholestasis. And EUS showed greater sensitivity in diagnosis of small stone, biliary sludge, and it is the only technique that can demonstrate changes in the wall of the bile duct, suggesting stone migration cholangitis, features of cholangitis. Coming back to more recent guidelines, a Cochrane systematic review of 2015 and other two older reviews well demonstrated that for a median pretest probability of 0.41, the summary sensitivity of EUS and MRCP is similar and very high, and the same is for the summary specificity. These are some limits of both the methods, EUS and MRCP. For sure, in altered anatomy, EUS has some limit. The limit is about invasiveness. The limit of MRCP are about the small stones. And again, the wide availability, the ability to image the intrahepatic bile duct, and this is something new, and with respect to the older studies, the cost effectiveness that could be better for MRCP than EUS. So these limits bring the NICE guideline in the UK to say that MRCP represents the safest and most acceptable test for patients in most cases of suspected common bile duct stones with intermediate risk of disease, but in some local situation, some skilled clinician endoscopist may choose to use EUS instead of MRCP, and in a minority of cases, both may be needed. But I don't think this is completely true, because the last word can be today be extracted from this meta-analysis of diagnostic test accuracy in head-to-head studies with a very strict selection of studies. No study presented a high risk of bias. And you can see that the pooled sensitivity of EUS is much higher and significantly higher than the sensitivity for MRCP. And also the overall diagnostic odds ratio of EUS was significantly higher than MRCP, mainly due to the significantly higher sensitivity. In conclusion, both EUS and MRCP provide good diagnostic accuracy, but EUS has statistically higher diagnostic accuracy and sensitivity with comparable specificity and should be incorporated into the diagnostic algorithm in patients suspected of bile duct stone. Speaking about money, you can see that in older studies, the US is the cheapest way of diagnosing stone, and if we look at patients with a likelihood of biliary stones inferior to 45%, the cost effectiveness of EUS is superior to that of ERCP. In these studies, it is a model-based cost-utility analysis, always from the UK, estimating mean cost and quality-adjusted life years. From the perspective of the UK National Health Service over a 1-year time horizon. And in this study, using MRCP to select patients for ERCP was cheapest than using EUS to select patients for the same reason. And initial MRCP was the most cost-effective option. But for sure, this is the perspective of the UK National Health System. There are several weaknesses from this study, and this data greatly depend on the country and the insurance system. So, in conclusion, I think that if EUS is available immediately, the endoscopy could perform EUS initially, and if positive, proceed with ERCP in the same setting, reducing the cost and not increasing the cost. And this could lead us to the EURCP concept, that is the concept of EUS and ERCP connection. Another, in my mind, important statement in these new guidelines is that in case of failed endoscopic common bile duct cannulation, when this cannulation is not possible also with the pre-cut, the access papillotomy, it is recommended that percutaneous, this is obviously the thing that we know from many, many years, but also the EUS-guided access can be considered both as rendezvous and antegrade techniques. We must recognize that in the setting of benign pathology, so in the setting of stones, there are limited data about the EUS-guided procedure, and there are few centers that have the facilities and the expertise to do this routinely. So we can take this whole study, but the conclusion of this study can be accepted also today. Patients with high probability of requiring intervention, cholangitis, obstructive jaundice, would be offered therapeutic ERCP directly. Low, moderate risk patients would be screened by MRCP. Where clinical concern for stone persists in MRCP negative patients, it would seem entirely appropriate to proceed to EUS. And I think that this is very important. We should move away from the idea that investigation merely exists to compete with one another, but accept that investigation often provide complementary information which ultimately results in optimum patient care. Another important point in evaluating the performance in diagnosing stone is the spontaneous migration of stones. That can be very high rate of migration if the stones are less than 8 millimeters, or if we wait 3 days, 18% of migration, or 1 month, another 18% of migration. This can be very important. As you already heard from the previous speaker, a diagnosis of idiopathic pancreatitis should never be made without a previous EUS. And when we are in front of a case of severe acute pancreatitis, you can propose EUS if it does not delay ERCP within 72 hours, if possible in the same endoscopic suite in order to rapidly proceed to therapeutic ERCP and sphincterotomy with the same sedation, and in a facility that allows ERCP and endoscopic sphincterotomy to be performed immediately thereafter the EUS. And better, in my idea, is if you can do it in the same session and with the same instrument without double intubation. How to develop the concept of EUS and ERCP connection? In my mind, the best way is the EURCP concept, that is doing both diagnosis and treatment of common bile duct stones, but also other biliary pathology, using the same instrument that can perform at the same time EUS and ERCP. And we demonstrated that it is possible with an old instrument. But there are also other ways to affront the problem of EUS and ERCP connection together in the same session with only one instrument. That is the extraductal ultrasound using a mini probe with a duodenoscope outside the biliary tract or the Wilson duct, and also the intraductal ultrasound. For the problem of choledocholithia, this intraductal ultrasound demonstrated very good data in the literature with a sensitivity of about 100% superior to that of cholangiography. And this is the last setting that of which we can speak. And the Swiss setting, again, tell us that the EUS-ERCP connection approach could be the better approach. After cholecystectomy, the patient can have residual or recurrent stones in 1-5% of cases. The biliary pain, cholangitis, or acute pancreatitis can be the clinical presentation, but also the sphincter of body dysfunction can be frequent after cholecystectomy. And this diagnosis, by means of ERCP and manometry, means bring with itself a severe risk of acute pancreatitis. In case of SOD, endoscopic sphincterotomy can be dangerous, but in case of residual or recurrent stones, endoscopic sphincterotomy is safer, with the same risk as in patients with gallbladder stones. And so we need the test in this setting with the best sensitivity and the highest negative predicted value for the diagnosis of stone or of sphincter of body dysfunction, that is EUS. But better, I think, EUS plus ERCP, that really represent the really integrated future, and in my mind, a new frontier in pancreaticobiliary imaging and therapy. And this is the issue that we will effort in the next 2 days in Torino with Peter Willman with us. And I remember also you that the EGOS Congress, the 8th European Congress, will be in December in Moscow next year. Thank you very much for your attention.